on the Omicron variant in New Jersey. I'm Oni Advincula, Project Coordinator for Ethnic Media at the Center and your moderator for today's conference. Our speaker today, Dr. David Adinaro, Deputy Commissioner for Public Health Services at the New Jersey Department of Health. He's someone most of you have met in our previous briefing. He joined us last year to update us on the Delta variant. And now, unfortunately, the Omicron variant is here. CDC predicted about 1.3 million new cases in 7 days, and that the death toll could shoot up to 71%, or more than 15,000 lives could be lost in a single week. Dr. Adinaro, I believe, is having problems with this video, so he will be voice only today. But he will be with us for the full hour to shed light on this highly transmissible COVID variant. So I am going to give the floor now to Dr. Adinaro.
All right, and thank you, Oni. And my apologies, I am actually at home today, given the fact that the roads and everything. So it turns out my video connection is not very stable on the Wi-Fi. So you'll get my voice more so than me on video, but I think that works out fine. I appreciate the invitation to come back. I think this is my second or third time with you all, and have enjoyed it in the past. I wish I was coming back to tell you that the pandemic was over and we'd won and that we're done. But obviously, we're in a new and different phase of this pandemic, and I will try to share as much information as possible, and then obviously happy to answer any questions that you all may have. So, I think it's important to point out that when we talk about variants, we are not talking about different diseases. And variants are something that is relatively new, I think, to the public, mainly because the ability to sequence viruses or bacteria or anything else is relatively new in terms of the scale that we are currently able to do it right now. And as you can tell, there have been a number of variants. We have been through, since the beginning of the pandemic, a variety of different things. We've had the Alpha, we've had the Beta, Delta, which first came into the United States around April and took about 2.5 to 3 months to become dominant, so that by the summertime, really almost all of the disease we were seeing in the United States, and specifically in New Jersey, was Delta variant. This is basically due to the fact that variant was essentially more contagious and transmissible, so able to outcompete the other types for the susceptible hosts. And at that point, we were somewhat fortunate that Delta, while it still was a fairly serious disease, was not causing more serious disease than we were seeing in the wild type. We were seeing an increase in cases, obviously, due to the fact that it was more transmissible than the previous variants or the wild type we had before. So starting what feels like only about a month and a half ago were the reports. Primarily, I think most of the data was coming out of South Africa. That doesn't mean the variant started there, but certainly that was one of the first countries that reported it. And then also had some of the largest number of cases, began reporting it. We first saw the Omicron variant reported in New Jersey at the end of November, beginning of December. And really our estimates that by New Year's, confirmed so far in the last full 2 weeks that we have the data, 35% of everything that we sequenced, which really is for those first 2 weeks in December, were the Omicron variant. However, if you take into account the likely growth pattern, and that's what the CDC does, and by the way, if you hear a dog barking in the background, that's just an added bonus because I'm at home. So if you look at the CDC predictions based upon that likely growth pattern, we are probably at a point where about 95% of the cases that are occurring in New Jersey or specifically they use region 2, which is New York, New Jersey, the United States Virgin Islands, and Puerto Rico, are Omicron. There's no reason to think that New Jersey would be any different than that. In fact, probably we're on the higher end of that. So it is realistic to think right now that the people who are getting sick with COVID really are being exposed to this Omicron variant. So the next question becomes, what's that difference between, Omicron and the other, what makes Omicron different or special, et cetera? I will always caution that I'm an emergency physician by training, so I'm not an immunologist, I'm not a virologist. But I think the good news is I tend to try to put things into ways that we can understand. It has a large number of mutations and deletions compared previously with the other variants. What that makes people concerned about, which seems to be coming true, is the fact that number one, that at least for the initial part of the disease, so in terms of infecting hosts, infecting individual people, it is good at evading the antibodies that may be available related to either a vaccine somebody's had or from previous infection. So again, we talk about natural immunity. The person who's become infected has had an immune response to this, that it looks like Omicron is better than the previous variants, and specifically Delta, at infecting people who have either been fully immunized, so at least 2 doses of an mRNA or at least 1 dose of the J&J product, or those who have been previously infected with COVID. The second part is this thought that despite that, it's the seriousness of the disease it causes is less than what we've seen in Delta. So in other words, if you took the same number of people who were infected with Delta and Omicron, you would see more hospitalizations in the Delta group. You would see more significant symptomatic disease in the Delta group. And in the Omicron, you would see less. What's obviously happening is, while it is causing, quote unquote, it has a likelihood of causing a less serious type of disease, the problem is the sheer number of people who are now becoming infected. The experience I think most people are having is even the people who are immunized, who are getting COVID right now, have symptoms that feel pretty uncomfortable for them. They may not be going to the emergency department. They may not be hospitalized and having respiratory symptoms, but they feel pretty miserable. And we still have an issue where, and we're still waiting for the data to come through, but I don't think it'll look any different. Those who are not immunized still remain at significant risk of being hospitalized and potentially dying. We are seeing the deaths related to COVID beginning to increase over the last few weeks, as the number of cases in New Jersey have also been increasing. So while it appears that, to an individual, Omicron may cause less serious disease, it still has the ability to cause very serious disease. And I think the biggest problem we're seeing, and this is affecting our emergency departments and a lot of other critical operations, are just the sheer number of people who are becoming infected with Omicron. I think the parts that are good news, first of all, is that there is some indication that while having been previously infected with Delta may or may not be helping you, and just excuse me 1 second, I'm just going to do something with my.
Dog is out there fighting the Omicron variant for us.
Sorry about that. Just a dog. So as I was saying, that while there's concern that those who had previously been infected, including with Delta, may be more susceptible to getting reinfected with Omicron, it appears that those who are being infected with Omicron are showing good antibody response and potential immunity to the other types of variants, including Delta. Though how much that will be beneficial given the amount Omicron has taken over, and we don't know whether those who have been exposed to Omicron develop a significant response that would make them less likely to be reinfected with the Omicron. So the other part of this is that what we're looking at with the vaccines, it does look like, though it is decreased, that those that are fully immunized, so those who've had 2 doses of an mRNA vaccine, as an example, excuse me, so Pfizer or Moderna, are still receiving significant, though reduced protection in terms of hospitalization or death or symptomatic disease as compared to Delta. What we are seeing, though, is that those who have been recently received their booster, so the person who's, let's say in my case, got 2 doses of Moderna and then recently got the 3rd dose of Moderna as my booster, are showing pretty high levels of protection from both symptomatic disease and levels that are comparable to the protection we were seeing against Delta with a primary series also. So again, the vaccines remain an incredibly important part of our response to COVID, even in the days of, even in this Omicron wave. And, you know, New Jersey, I think, has done an incredible job. We are now at 87% of all those who are eligible for a vaccine. So those 5 and above, because that's who are now eligible for a vaccine. So 87% of those 5 and above have received at least 1 dose of the vaccine. And about 75% of those 5 and above have completed a primary series. And roughly about 45% of those that are eligible for a booster, so currently those who are greater than 6 months after their full series of an mRNA or 2 months after their first J&J dose, have received a booster. And when you look at the most vulnerable in terms of age, which are those over 65, it's actually closer to 65%. We're obviously going to be changing that denominator now that the federal government, CDC, has said that you're eligible for a booster 5 months rather than 6, and have added potentially after today the 12 and above to being eligible for a booster. That will obviously increase those who may be eligible to receive a booster. So again, majority of the significant disease we are seeing in our state are in that very small percentage that are not vaccinated. And I think it's important to talk about the fact that even though it is true that those who are younger are less likely to be hospitalized or die from COVID, we are still seeing significant symptoms in school-age children. And unfortunately, we are seeing recently an increase in both hospitalizations and death related to COVID in school-age children. And that is likely just related to the sheer number of people who are now becoming infected with at first Delta and now the Omicron variant. So statistic-wise, today we are reporting, I believe, over 38,000 positive PCR and rapid antigen tests in the state of New Jersey. Always, I think you should keep in mind that from a state-to-state comparison, probably the PCR positivity, which is about 30,000 cases, is what most sites like COVID Act Now use, because all states consistently report that. We also recognize that a lot of the home tests that are available, if you're buying it at a convenience store or a supermarket or a pharmacy and administering it at home, there's no easy way from those manufacturers of those tests to report your positivity. So we know that there may be some underreporting, but that probably has not changed greatly. Hospitalization right now, where about 3.5 weeks ago, we had roughly 1,900 patients in the hospital with confirmed or suspected COVID. As of this morning, it was over 5,500 hospitalized, with over 700 of those patients in the ICU and over 350 requiring ventilators. Again, I think the good news is that a smaller percentage of patients are requiring hospitalization, and a smaller percentage of the patients who are being hospitalized require intensive care or require intubation and being placed on a ventilator. But still, as those numbers increase, we are going to see potentially an overwhelming number of patients in the hospital. At the same time that our hospitals are also busy taking care of a large number of people who are there for chronic diseases, and of course, what is shaping up to be a fairly normal flu season in New Jersey, as opposed to last year, we had very little, if any, flu. We're already in the moderate category for influenza. And that kind of lines up with what we saw in 2019 and 2020. We were fortunate, I think, that distancing and a number of other things last year had really kept flu cases down, along with COVID cases. And then, for deaths, obviously, we are beginning to see deaths always, unfortunately, lag behind hospitalizations and symptomatic cases or newly lab positive cases. So we are beginning to see an increase in the number of deaths related to COVID. Again, I think we're waiting for more national data related specifically to what that rate of death or serious hospitalizations looks like in comparison to the number of cases. But we are still in an environment where we have not reached our peak in New Jersey, and we will still see cases continue to increase, for a foreseeable period of time. The one country that I think everybody does look to has been South Africa, which did show or has been experiencing a rapid decline in its cases that matches somewhat their rapid increase in cases when Omicron came. It is too early to tell if that is something that we should expect in the United States or not. And again, while we're going to wait for more definitive data, I think it's important to point out that the majority of the people who are being hospitalized for COVID, unfortunately, are in that roughly 15% of the population that is not immunized, have not received at least one dose. So, while we certainly are beginning to see the effects of these large number of cases leading to hospitalizations of people who have been fully immunized, this is still a disease that is having a very serious impact on those who have not either started or completed a primary series. Just for a moment, I want to talk about what the state and the Department of Health in particular have been focused on. Obviously, all the safeguarding remains in effect. The emphasis that people should be we should be wearing masks in public, should be social distancing, should be isolating themselves when they become symptomatic until they've been tested, and the importance of, particularly for those that are not immunized, when they've been exposed to other individuals, to quarantine. As I think most of you are aware, the CDC has recently made some changes around their recommendations for isolation and quarantine. They've done this around the data that they have, looking at the transmissibility, and obviously, I think it's important to emphasize, while they have reduced the amount of time that somebody should isolate if they are positive for COVID or quarantine if they've been exposed, that even in that shortened period of time, the importance of considering being tested, of wearing a mask out in public after you've completed that initial period of time is still incredibly important. And certainly for individuals who are going to be around high risk people. So, for my family, taking care of my 93-year-old father, using an abundance of caution around maybe considering lengthening or keeping the quarantine or isolation period closer to that 10 to 14 days, I think makes a lot of sense. And I think people have to make some individual assessments on it. From a state point of view, we have a lot of things going on right now. Obviously, we still continue to emphasize vaccines. Vaccinations did decrease somewhat during the holidays, certainly with some of the vaccine sites being closed for a day or two around the major holidays. but we are seeing a rebound. We are averaging about 50,000 individuals a day coming in to get a vaccine every day. Some of them, a large portion of that are people coming in for a booster, but we still have a good number of people, including school-aged children, who are the largest group that have not been immunized or started the immunization process, coming in to get their first dose. It is never too late to start the vaccine. We may be in the middle of Omicron. You may have been infected with COVID in the past, but the importance of getting the vaccine has never been more relevant. COVID is not going away. What it looks like in the future, we don't know yet, but I think it's fairly safe to say it is going to be with us for a long time. So the importance of getting vaccinated remains as critical as always. And we have over 2,000 locations in the state of New Jersey that are regularly vaccinating, everywhere from mega sites. We have 3 operational and 2 more coming up, to obviously a lot of local pharmacies and primary care offices that are also offering the vaccine. The state of New Jersey, along with help from FEMA, has been increasing the accessibility of testing. I think testing has obviously has drawn a lot of attention. We are seeing a large increase in the number of tests being reported in the state of New Jersey. So in other words, being processed by some of the major laboratories. We're also recognizing that the time from when a sample is obtained to when a result comes out has been increasing also recently. And a lot of that, besides volume, is being attributed to the fact that the laboratories themselves are experiencing a large number of staff and laboratorians who are sick with COVID and are at home. So that is slowing down their ability to expand testing. We do have a FEMA, or so I should say, a federal run site located in Essex County that can do up to 1,000 tests a day. And we've been working very closely with the county and local health departments and a number of others to increase testing that's available. I think the other last 2 things to talk about in terms of the state response are we now have 3 different types of therapeutics available in the treatment or the prevention of COVID. On the prevention side, besides vaccines, we now have an injectable, essentially a monoclonal antibody that is preventative. It's called Evusheld. It is designed for individuals who are significantly immunocompromised and may not mount an adequate response to the vaccine. So it's basically a preventative medication. It's an intramuscular injection. You get 2 over a month-long period of time. It is designed to protect you from COVID over the space of 6 months. We have a very small supply has begun coming into the state that has been focused mainly getting to some of the larger medical centers and infusion centers that take care of people who are undergoing chemotherapy or other types of treatments like that, individuals who've had solid organ transplants. We also have the monoclonal antibodies, which I think many people are familiar with, that have been available. Unfortunately, with the now dominance of Omicron, only one of the 3 existing monoclonal antibody therapy treatments are effective against Omicron. So that has really decreased the amount of the availability of monoclonal antibodies. We distribute it currently to about 90 different sites every week. And the state does not possess these medications. We allocate and then they're distributed through partnership that the federal government has. So we're not stockpiling anything in New Jersey. All of it gets out there. And the other 2 that have recently become available are these oral antivirals. The first one from Merck, which is molnupiravir, and the second one from Pfizer, which is Paxlovid. Both became available. Again, the initial allocation to New Jersey was a very small amount of both of those medications, and we have made them available at about 24 Walgreens pharmacy locations throughout the state. Those medications have no cost. The oral antivirals, again, the monoclonal antibodies and the oral antivirals have the same target, which is to be treated, to be for early treatment of COVID positive patients who are at a high risk of either hospitalization or death due to COVID. So they're not really there for reducing, let's say, significant symptomatic disease. We're really asking the providers that are administering them or prescribing them to really focus on individuals who are at high risk. And, obviously, those would be, particularly people who have comorbidities, so diabetes, hypertension, morbid obesity, the things that we've shown that put people at risk of not so good outcomes from COVID, along with things like vaccine status, et cetera, and obviously age will be some of the factors that we're looking at. All those therapeutics are in incredibly short supply. All of them are allocated by the state based upon the amount that the federal government allocates to us. And we're trying to get that out as effectively as possible. Over the next few days, we're going to be increasing the amount of information that we're providing both to healthcare providers to educate them on the use of these and encourage the use of them, and along with the public on where to locate them and their availability and some of the other information. It's been this has expanded rapidly. Obviously, number of these medications, the Evusheld, the preventive medication, and these oral antivirals didn't exist as something available to us until really a week or so ago. So we're playing a little bit of catch up in the state, but really trying to get as much of that out as possible. And then the last thing I think we got to focus on is obviously in the desire to support our hospitals and our long-term care facilities who are really feeling the effects of an overwhelming demand for the services, particularly the hospitals. So a number of the things that we're trying to make available, my boss, the Commissioner of Health, and the Governor's Office have been working very closely with the hospitals in New Jersey to help coordinate activities to make sure that they have anything that we can provide, such as additional space, beds, and things along those lines. We have a lot of PPE, so personal protective equipment and ventilators stockpiled. So far, not getting a lot of requests for either of those, but things that we were very short of at the beginning of the pandemic, we now have available. Their biggest request, quite frankly, is for personnel. If you think back to March and April of 2022, New Jersey was able to draw on, our hospitals were able to draw on a number of pools of help that are not currently available, travel nurses from other states, Department of Defense personnel who came in, medical personnel who came in to support our hospitals that may be, deployed to other states or in other activities. We had nurses that were working in school districts or in ambulatory care centers that were shut down during the pandemic, who were voluntarily redeploying themselves to other places. Those pools are not necessarily going to be available this time around. We're not the only state, or one of a handful of states, seeing a large increase in cases, but we do have some resources, and we're very excited, as an example, that the New Jersey National Guard are going to be supporting operations in a number of long-term care facilities starting in the next few weeks. This was something that was very successful back in the beginning of the pandemic, and it's the response of the National Guard to train its troops to help provide that's been amazing. We've also done things that to try to free up some of the higher level providers, particularly nurses. So one of the things that's happened recently is we've issued guidance and a waiver and some education so that EMTs are now able to participate as vaccinators in the vaccine program under close supervision with training as appropriate for the training. But we hope that increases the number of people that are able to essentially put shots in arms safely, which may then free up nurses to be doing some of the other things or increase the hours, because we know that a number of centers have been losing staff either to more pressing priorities like inpatient care or for staff that has been sick. So we are very much focused on a number of surge related activities and preparation. As we know that likely there'll be more people in a hospital tomorrow and the next day than there are today. And part of that obviously is working closely with our federal partners, including FEMA, to talk to them about our needs and to see what is available on a federal basis to come in. I think I will stop there if that's okay. I think I got to
Yes.
most of what was on the agenda. And then obviously I'm happy to take any and all questions.
Okay, thank you, Dr. Adinaro. We truly appreciate this vital information that you share with us. We have a number of questions, and let's start with Joe. This is actually a very interesting question, and we talked about this. If someone is tested positive for COVID, how do you figure out which variant that is? Because when you get the test, you only get either positive or negative, but you really don't know whether it's Delta or Omicron. How do you figure that out?
Sure. So a couple of things. I mean, obviously, from a surveillance point of view, our state lab and then the other national labs sequence a certain percentage of the cases. In general, what variant you may have probably does not affect your care as much, particularly now that we think that about 95% of the cases are Omicron. Pretty much if you're being infected with COVID right now, you have Omicron. If you were infected with COVID in October, let's say, you can be pretty sure that you have the Delta variant. So there's really no other way to tell other than the sequencing. And for most people, knowing exactly what variant you had probably would not change what you would do or what we would recommend for your treatment. If there's somebody that there's some specific concerns, and it's important to know, obviously their physicians can order sequencing, but the sequencing can take up to 2 weeks to complete. At the very least, it's 3 or 4 days on the instrument. So it's not something that's readily available immediately.
Got it. Thank you. The next one is from Alexandra Slavish of Novigenic. Her question is, what is the major disruption of Omicron in the state of New Jersey? Does this cause hospital overload, lack of the workforce, or any other things?
So I think the simple answer is all of those things. Our concern, I think we're concerned about a double hit. If it was just the fact that a large number of healthcare centers, whether they're doctors' offices or hospitals with inpatient units, are seeing a significant proportion of their staff out sick, or it was that we're getting a very large influx of patients that are rivaling the numbers we saw last winter, or even getting close to the number of patients that were in the hospital at the beginning of the pandemic. Either one of those would be less serious than having both of them at the same time. We know that, particularly if you look at nurses, most healthcare settings were short nurses. Before the pandemic started, they were very short of nurses before this wave started. And then if you're taking a certain percentage of them out of action because they're sick with Omicron, or they become sick because of Omicron getting through their defenses, particularly initially, that is causing a large problem. I think the one thing we're not anticipating seeing is, while our hospitals will probably continue to fill up, because it's a smaller percentage requiring the ICU, our ICU capacity and our ventilator capacity may not become overwhelmed, but the rest of the hospitals likely, and the rest of the healthcare system is likely to become overwhelmed. I think we're seeing across the board in a number of different service areas, whether it's schools, whether it's the laboratories that are doing testing. I'm sure delivery companies, as more and more of their workers are sick, their abilities to maintain regular operations are being seriously impeded.
Thank you. Our next question, this is somehow personal because she was tested positive of COVID on December 24th. Marie Veer, would you mind asking your question?
Yes, hi Oni, thank you. My question, doctor, is the situation was I had COVID on December 26. 24, I had my sore throat. Then now I tested negative using the home self-test kit.
Mhm.
I just had a sore throat and was very productive at home doing house chores and writing. And I had my booster. But my concern is the booster is only for 10 weeks. So is it recommended that I take the monoclonal IV infusion and I will be able to get rid of having boosters?
Okay, so the booster's not for 10 weeks. We obviously don't know how many, whether people will need a yearly booster, et cetera. I think what you're keying on is the reports that the antibody response from the booster is for the first few months, and the antibody part begins to wane. I think it's important to know or talk about the fact that there's two different parts of your immune response. There are those antibodies, those are your frontline troops, those are the ones who respond immediately. And then you have the other parts of your immune response, the cellular response. That's the slower one, but that's the one that does most of the work. So this is why we see, I think, with Omicron, even with people who, let's say, have not been boosted yet, we see breakthrough disease for symptoms. We don't see severe disease, and that's related to the antibodies versus the T cells and the memory cells, et cetera. So at this point, you don't have to go back for anything else. You assuming that you don't fall into a category where you would need an additional dose because you're immunocompromised, et cetera. You've gotten your booster now. So there wouldn't be really anything else for you to do. I do think you bring up the question, which is, we don't know whether or not we're going to recommend boosters every year, boosters every few years, when it becomes more a focus on the totality of immunity versus what we've been tracking with the antibodies. I think that's more information that will come as time goes on. Hopefully I answered your question.
Thank you. Thank you, doctor.
Thank you. The next question is from Clyde Hughes of the New Jersey Front Runner. And he is wondering how Omicron is affecting the Black and Brown communities in New Jersey as compared to other communities.
I have not personally looked at the breakdown of the cases by communities of color, to be honest with you. Obviously, we are seeing a large number of cases coming from our most populated counties. So as an example, Essex County is seeing a very large number of cases right now. So those that are living in closer quarters seem right now to be experiencing more spread of it. But I haven't seen anything that I haven't quite honestly looked at. I think the data probably takes a couple of weeks for us to really break it down to the gender and the race and ethnicity level to really see if we're seeing any trends. So I think it's, I'm sure that they are being impacted because they were impacted before. I think what is probably mitigating is the fact that we did make great strides. Those communities made great strides in getting vaccinated and boosted over the last 6 months in particular. But I don't think I have any more specific data to share.
Thank you. Our next question is from Clybill Marcano of Reporte Hispano, and he would like to ask his question.
Hello. Hi, do you hear me?
Yes.
Yep.
Yeah, one question. How many infections we need to have in New Jersey to say that we reached the peak? Because you say we are not reached the peak yet, so how many infections we need?
Well, that's a good question. I think you don't know if you're at the peak until you start seeing your numbers go down, to be honest with you. So the reason why I think we all feel pretty sure we have not reached the peak is that right now our RT, so that reproduction rate, so 1 would be steady state. Anything below 1 would be our numbers are falling. or will expect to continue to fall. Right now we're at 1.7. This is the highest I think New Jersey's ever had. So I don't think we'll know that we've peaked until we start seeing the numbers go down. But it's fair to say that right now we're not showing any indication that we're beginning to see a slowing of the acceleration rate. Let's put it that way.
Yeah, and the symptom for this Omicron is different than the Delta because, for example, I remember that one of the main symptoms for the COVID is that people lost the smell and some other symptoms. But in this case, we don't hear about this. If we hear that the symptom is like a regular flu.
So it seems, I agree. We are definitely seeing people report a different prevalence of symptoms. So I would say this time around, the things that remain common are the fever and the body aches and the fatigue, I think have remained the same. I think you're hearing more complaints of headache and sore throat this time around. And you're hearing a little bit less in the cough, shortness of breath, and loss of taste and smell. Though we are still seeing some of that, but I agree it does, the types of symptoms people are describing seems a little bit different with Omicron. But again, we are also seeing still a significant number of people who have symptoms that are bad enough, to be in the hospital, and that's usually driven by respiratory symptoms, obviously.
Thank you. Now, Dr. Adinaro, here's a very basic but important question. How effective are rapid antigen and PCR tests? Are they detecting Omicron well enough? What is your advice on testing?
So it's a good question. We don't have any conclusive data that suggests that the rapid antigen tests are less effective now with Omicron. I think there's some anecdotal reports of that, but I don't think we've gotten enough data to say. I would say that if somebody administers a rapid antigen test themselves or has one administered and they're symptomatic and it's positive, then I would believe it. I would say if you're having the symptoms that are like COVID and you've done a rapid antigen test and it was negative, I would continue to mask and avoid people and then retest yourself in a day or two or consider a PCR test because we are seeing some people who test negative once, maybe it's because it's earlier in the disease, and then they test again in a day or two and they're positive. So I think a positive test, it says you have it. I think a negative test, you have to kind of evaluate your symptoms and think about maybe testing again in a day or two.
Thank you. Our next question is from Matt Scofilis, and he would like to ask his question.
Hi, Dr. Adinaro. I have a couple of questions. Please bear with me. I'll try and be brief. Number one, is this the moment of the COVID endemic where we see the virus becoming weaker and less fatal? Or are we, potentially poised to face an even nastier mutation? Second question is, Murphy said that the dashboard totals are to be considered a floor for case counts. So is there any estimate about how much higher above that baseline, the unreported numbers, the home test numbers would bring the actual total? And finally, do you have any thoughts on pandemic fatigue and or how to rally social behavior at this stage of things? Because people seem like they're either incredibly hypervigilant or incredibly reckless with very little middle ground.
So speaking of fatigue, I think it's impressive that you think I'm going to be able to remember the first question when I got to the third one, but I'm going to try to answer all of them, but I may need some prompting from you. So in terms of the floor question, we don't currently have a great estimate on how many people we're not capturing because they just did an at-home test and there's not any great way to report. There are some survey companies that are beginning to trying to do some work nationally to get a better handle on that. But I don't think we've seen anything in New Jersey yet. And I'm sorry, what was your first question again?
Yeah, absolutely. One of the other questions was, is this our endemic or pandemic to endemic moment, or are we looking at potentially more nasty mutation?
So I would love to think that if we had to live with any of the variants, if we had to live with either Delta being endemic or Omicron being endemic, I would say right now that Omicron would be the one you would prefer. But at the same time, we really thought that, when Delta became dominant, I think if you had told us that there would be another variant that would become dominant within a few weeks rather than a few months of coming into a country, I don't think we would have been expecting that. And we also know that since Omicron, there's been several other variants that have been identified that, or that haven't made it to the level of being a variant of concern, but I think it's always possible. I think obviously if there was going to be something that would outcompete Omicron, it would really need, Omicron is very, very good at infecting people. And it would be impressive to find another variant that would be even better than Omicron. But of course, you're talking about something that's very scary, which is there could be one out there that would be able to outcompete Omicron, but also cause more severe symptoms and outcomes. And I think that, again, goes back to the importance of vaccine. We are still seeing the majority of our hospitalizations and death are in those who are not fully immunized. And I think that is even though that's a very, very shrinking pool of people in New Jersey, it is still a pool of people that are at incredible risk compared to the rest of society. And then for your last one on fatigue, it's a good question. We certainly, I think people always are good at, and me in particular, I'm great at gearing up for things when I know that there's an endpoint. I can focus on the journey, but I like to sometimes feel that there's a destination, and I can understand people's fatigue in not fully understanding what's the destination or when we get to, as you're talking about, that endemic point where this is where we are, and then we figure out how to live with that. And none of us really know when we get to that point yet. So, but again, I think the consistency of messaging is incredibly important. And I feel very proud to be in New Jersey and to have, one of the highest vaccination rates, and to see people consistently wearing masks when I'm in my local pharmacy or or for me at work with the Department of Health, obviously, or if I'm in the store. But I definitely understand your question about how do we get people to kind of continue to do things once they're tired. Hopefully I answered your questions.
We have less than 10 minutes left, and we have about 6 more questions. So I will be reading some of those questions, and I will ask a couple to ask their questions. The first one here that I'm going to read: how is South Jersey being affected by the spread compared to other communities? New Jersey has one of the highest infection rates in the country. Why is that?
Why do we have one of the highest infection rates in the country?
Yes.
That's a good question. I don't think we have a specific answer to it. Clearly, Omicron, I think, has, I think if you look at the other waves, New Jersey has always had slower peaks, and then we've had a slower time getting to the trough. And this is really the first time since the beginning of the first wave of the pandemic when we've gotten just such a large and overwhelming ramp up so quickly. Certainly, we've always pointed to our density as one of the reasons for it. But if you look at, I think there's all but a handful of states that are now at the highest level in some of the mapping. Why we're experiencing this versus why Florida experienced what they had in the summertime, I don't think we really know. But I think obviously our density always plays in our favor in some things and against us in other things, to be honest with you.
Thank you. Kevin Coughlin has a question for you, Doctor.
Hi, Doctor. two quick questions. You spoke a little bit about the staffing shortages in the healthcare system because of COVID. I was curious if you're seeing also the impact of the Great Resignation. Has the pandemic taken such a toll that you're seeing a lot of people just retire early or move to different careers? The other question is, any thoughts about the possibilities of long COVID from Omicron?
So I'll do them in reverse order. Don't have a lot of information. Obviously, we don't have a lot of information about long COVID to begin with. So it's a little unclear if where Omicron will be with that as the first part. For the second one, absolutely. Healthcare had experienced a large shift in its workforce over the last 6 months. And so it was already a depleted workforce coming into this surge and then losing people to the disease itself. I've been in healthcare a long time. I think we had a lot of nurses. Nursing is a profession that's a little bit on the older side in terms of the average age. And quite frankly, we also just have such a larger demand for healthcare providers. There are so many more things that nurses in particular can do that is beyond just bedside care or office-based care that are meeting the demand. So we've also created, it's not only just that we've lost nurses and haven't replaced them. I think also nurses are now in demand for so many different things. We have nurses running a vaccine program that is still doing a couple 100,000 doses a week that didn't exist before that we need to fill those slots in. But without a doubt, I think the workforce is impacted.
Do you have any statistics, doctor, on just how much the hospital staffing has been cut back in this way?
I don't have any. I would go with check with the New Jersey Hospital Association. I haven't seen any specific ones for New Jersey, but definitely the sense is that almost every healthcare facility has experienced a large change in its workforce over the last year.
Thank you. Let's give Sal DiMaggio an opportunity to ask his questions. I believe he has a couple.
Hi, Dr. Adinaro. I have two questions. The first of which being, how does the Omicron variant affect young adults ages 18 to 24, and how could this affect us? As colleges and universities open for the spring semester in the next couple of weeks. And then two, how is being forced to deal with variants such as Delta and now Omicron made us better prepared to deal with future variants such as the IHG1, which has 46 mutations?
So clearly we're seeing all age categories are showing a large increase in infections, and younger individuals are showing larger increases. So school-age children and young adults are seeing larger increases in cases compared to, let's say, those above 50. Certainly, some of that is driven by the fact that Omicron is highly transmissible, and a lot of it's driven by the fact that the groups I just named, so school-age and young adults, are the ones who have the lowest vaccination rates in our state. And we are seeing, because of even though it's still proportionally not a very large number of them, we are seeing increases in hospitalizations in those age groups also, as larger numbers of young adults and school-age children become infected. I think in terms of preparation for either future pandemics or other variants, clearly our capacity to sequence is much better now than it was at the beginning of the pandemic less than 2 years ago. The amount of testing, even though it's not nearly enough, the amount of PCR tests that can be accomplished and the amount of rapid antigen tests that are available is much larger now than we had before. I think the fact that we're at the beginning of what's going to be hopefully an ever increasing supply of these treatments for COVID. So again, the oral antivirals, the monoclonals, things like Evusheld for preventative, I think are going to be incredibly important and have been important. The monoclonals have been hugely important in helping reduce hospitalization rates. And, as we get more information, I'm hoping to hear and see the same thing for the data on the oral antivirals. And again, I think we have to go back to the fact that despite the fact that we are now on, I don't know how many variants of concern, and now we're in our second dominant variant, first Delta, now Omicron, that the vaccines have really held up extraordinarily well, particularly in protecting people from the most serious consequences of the disease. And that gives me hope that, as we see other variants, that those same things will help us out.
Okay, Doctor, we have here 3 questions that I'm going to combine. The lines for COVID testing are still prohibitively long. One also has to wait for an appointment for a booster. Is there any plan at the state or county level to alleviate the wait times? The second one was parents are concerned to send their children to school at the time while there's a surge of Omicron cases. How do we address those concerns?
Okay, so we are definitely working with all of our partners, but particularly county and local governments, to try to increase access to testing. And we've been doing that through a number of ways. Some of them are our own deployable teams. As I've mentioned, this federal team that is currently in East Orange. I think there's a possibility of another team coming in shortly to help out in another part of the state. We've also been working to try to increase testing availability through the counties or in partnership with the counties. Certainly for vaccines, we now have 3 mega sites in Gloucester, Burlington, and Somerset counties. We have 2 other locations that should be coming online over the next week to 2 weeks in the northern part of the state. And I really want to encourage people. I realize that if you go to the scheduling of some of the larger chain pharmacies, you may have a 2 or 3 week wait in order to get an appointment for a vaccine, whether it's a primary one for your children or a booster one for yourselves. But we also have a lot of other vaccine, whether it's a pop-up clinic that's going on, or quite frankly, some of the independent pharmacies have appointments. So I think spending some time looking around, looking at our Vaccine Finder website and expanding your search beyond, let's say, the Walgreens, the CVSs, and the Rite Aids, who are doing an amazing job and are our backbone, but maybe having longer appointments are going to be important. We do know that we'd like to expand, and certainly past the holiday, we have been expanding the number of vaccination teams we have out there, the hours of some of our mega sites. And then, for the school-age children, right now, anybody above the age of 5 is eligible for the vaccine. We know the vaccines are protective. We know the vaccines benefit. We understand that, parents who have questions, concerns can talk to their healthcare providers about the risks versus the benefits, et cetera. But I can't emphasize enough that whether you're concerned now or whether you're concerned a year from now, COVID's not going anywhere. And getting your child vaccinated is really the first and most important step in protecting them.
Thank you, Dr. Adinaro. We cannot thank you enough for your leadership, for your expertise, for your time. We really appreciate it. And thank you, everyone. I know there are a couple of questions that have not been asked. So we're just going to send it to Dr. Adinaro. We'll just email you with those questions.
Sounds good.
Yeah.
All right.
So thank you, everyone. This meeting is now adjourned.
Thank you.
Thank you.